This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Hello, I'm Gavin Stetson, past president of the American Academy of Otolaryngology, Head and Neck Surgery, and chair of the Academy's Future of Otolaryngology Task Force, and a partner at Albany ENT and Allergy Services in New York. I'd like to welcome you to episode 15 of the Academy's COVID-19 podcast series. This episode will cover part 2 of our guidance to return to practice document relating specifically to specialty surgery guidance. As you know, in this unprecedented time of the coronavirus pandemic, we are returning to practice with a lot of uncertainty, lacking certain evidence and science, and looking for best practices to be able to guide surgeons optimally in resuming their practice. I'm very fortunate and pleased to be joined by an illustrious panel representing various otolaryngology subspecialty areas for this podcast. I'm joined by Albert Maradi, past president of the Academy and Chief of Laryngology at the University of Washington Medicine Head and Neck Surgery Center. We're joined by Sujana Chandrasekhar, past president of the Academy and a partner at ENT and Allergy Associates in New York, and associate clinical professor of otolaryngology at Mount Sinai. We're also joined by Sherry Ann Nathan, president of the American Head and Neck Society, and chair of the Department of Otolaryngology Head and Neck Surgery at LSU in Shreveport, Louisiana. In addition, we are joined by Joseph Hahn, president-elect of the American Rhinology Society and professor and medical director for the Division of Allergy at Eastern Virginia Medical School. And we are also joined by Margot McKenna, associate professor and director of pediatric otolaryngology at the University of Rochester Medical Center and Golisano Children's Hospital. This guidance process was a truly collaborative opportunity between the American Academy of Otolaryngology Head and Neck Surgery and its related committees, partnering very closely with the subspecialty surgical societies and their related staff to really, in very short order, produce documents and guidance that have helped inform part 1 of the guidance and certainly part 2 as it relates to the surgical management of the otolaryngology head and neck patient. Specifically, I would like to thank the AAOA, the ABEA, the ALA, the ANS and AOS, the ARS, the AAOHNS, ASPO, and the International Surgical Sleep Society. This was a we are one moment with tremendous effective communication and collaboration, without which these guidance documents would not have been possible. So I thank you all for your participation and support in this process. The purpose of this document is to provide guidance, but to recognize that it's a living document that as evidence and practice patterns change or become more evident in the future, changes will be made to this document to facilitate optimal use. This is an important time. There's a lot of uncertainty. What we are trying to do is look to the leadership to define what constitutes representative timing for return to surgery, what constitutes an emergent or urgent procedure, what is time sensitive, what might be routine or normal, so that we can have representation in talking to our surgical committees, surgical booking committees, our local hospitals, regional representation, Department of Health, and so on, to help facilitate safe return to the surgical environment. So having said that, we'll talk about some of the common areas which were addressed in part 1 of this document, consideration to different surgeries in different subspecialties with potential for aerosolization, the theoretical risk of transmission of the coronavirus, COVID-19, as well as resources related to PPE and how it relates to individual practice that can be extrapolated across the country. So having said that, I'd like to turn to Dr. Sherry-Ann Nathan first. And Sherry-Ann, if you could share your perspective as it relates to the challenges in head and neck surgery and provide a little overview as it relates to head and neck surgical management of these difficult patients, the oncology patient, timing of surgery, OR specific issues, and maybe even PPE and other factors as well.
Thank you, Dr. Stetson. So, fortunately, head and neck cancer care has fallen within the urgent group of patients who have continued to get care at many centers. However, clinic visits, surveillance of cancer patients, whether one should perform flexible endoscopy to diagnose tumors in clinics, and many of the non-mucosal tumors, I think, have been placed on hold in many centers that have been overwhelmed with COVID-19. However, those procedures or those tumors that obstruct the airway, that have caused significant bleeding or resulting in acute or impending neurological change, patients have continued to get their care at most cancer centers. I think, part of the problem has been patients themselves being reluctant to come in to have their tumors diagnosed, especially if they have smaller lesions, say, of the oral cavity. As we know, many of these tumors grow rapidly, and we have seen patients that started off probably as, T2, T3 tumors, but being close to the mandible have had involvement of the mandible requiring larger resections. So I think, unfortunately, we haven't seen this wave of patients yet, but as our clinics start to open up, I think throughout the country, we're going to see advanced stage cancer patients. And I think, being in Louisiana, we saw that during Katrina, where patients started to come in when things ramped up and care was available. But I think PPEs have been available at most of the operating room regarding head and neck cancer, because those are mucosal procedures, and we have continued to use PPEs. And that mostly has involved N95 masks. I think patients have continued to get tested for COVID. If they are positive, we have delayed the surgeries, unless, of course, it's an airway obstruction. Larynx cancers in particular that have been T4 with obstructive tumors have continued to have laryngectomies. Dr. Stetson, at our hospital, within our department, we have had a weekly conference where we go through all the cases that various faculty have posted on the OR schedule. And many of the non-mucosal cancer cases, so within head and neck, we have a number of sections in the Head and Neck Society. We have the endocrine section, cutaneous, mucosal, which we just discussed, the skull base section, and then we have the salivary gland. So for instance, talking about cutaneous tumors, melanomas, especially if they're greater than 1 millimeter, have been allowed to go. Merkel cell carcinoma, the large basal cell carcinomas closer to the orbit or closer to critical structures in the face, advanced stage high-risk squamous cell cancers of the skin, immunocompromised patients with parotid and nodal mets. We have definitely prioritized those skin cancer cases. Similarly, for endocrine, if it's an anaplastic thyroid cancer, medullary, papillary thyroid cancer with large nodal metastasis, or based on the location, if the recurrent nerve was paralyzed, So you know this is an invasive papillary thyroid cancer. Those cases have definitely continued to proceed. In fact, even Graves' disease, if it's life-threatening or severely symptomatic Graves' disease, patients have continued, to have surgery. In terms of parathyroids and hyperparathyroidism, if the calcium is greater than 13 and the patient's really symptomatic, that has been more of an urgent, obviously not an emergent case. Salivary gland tumors, again, the high-grade tumors have continued to proceed, but the low-grade tumors, and the benign tumors, we've held off on those and we'll wait till things start to ramp up for salivary. And then, of course, the infections, abscesses, and have continued to go. So I think other than skull base, those have been most of the subspecialties within the American Head and Neck Society that we've covered.
Excellent. That was a very nice comprehensive overview. Just one question, and we've seen at different institutions, availability or delays as it relates to ultrasound guided biopsies and other procedures, and reluctance to perform and or delay. Any concerns regarding, obviously, like you'd alluded to, delay in diagnosis or the reluctance of patients to venture into a hospital environment?
Yeah, so we have definitely seen that it has been a lot harder to get ultrasound guided or any image guidance biopsies, and patients are reluctant, like you said, to come in. So for obvious palpable masses, we have continued to do our own fine needle biopsies and ultrasound guided biopsies. But as we all know, at many cancer centers, being a tertiary care, patients come from far, and often we try to get the scans and the biopsies done at their referring institutions, and that has definitely had delays. But once the patient has come in to see us, we've gone ahead and performed the needle biopsies.
Excellent. Thank you. So there's a certain amount of overlap in the different sections, and we'll certainly circle back and talk about some other common themes. But I'd like to transition to Dr. Muradi for a discussion about laryngology and the aerodigestive tract. So Al, if you could please share some of your perspectives.
Thank you, Dr. Stetson, and thank you to our Academy for keeping the communication rich and frequent, and I think it's been very valuable to our members, I feel. What Dr. Nathan presented is critical. Interestingly, in laryngology, as you know, I'm an otolaryngologist who focuses on laryngology, and when I think about the diagnostic aspects, that's something that we share, right? Most of the things that laryngologists do are also done by folks who have a big, broad practice. We may have a diagnosis we focus on more than others, or have a little more experience in one area than others, but understanding how we're going to do diagnostic endoscopy in the office is really the main dish. The specific parts of the operative decision-making, triaging, I don't know if that's the right word, are important. Like Dr. Nathan said, like my colleagues are probably going to say, can't breathe, bleeding, these things are not difficult. And I haven't heard of any pushback on this from around. Impending airway obstruction, aspiration to the point of pneumonia that has a surgical solution, those things are moving forward as they should. And I think when we recognize, as things have gone from, for example, our guidelines were what can be postponed for a month. Now, what, at least in my institution, what can be postponed for 3 months? Most of what we do needs to really happen in a relatively, within a short few months, or patients will suffer. Patients will have communication issues, workplace issues, Zoom calls. This stuff matters, and our patients need us in this regard. So the tiers that are so clearly written in this document, which is coming out, which will be out The emergent is clear. The urgent are generally clear. Impending airway obstruction, progressive dysphagia, worry for cancer, that sort of thing. The time sensitive, the T1, right? That's important, right? T1 better than T2. Let's get on it now, but does it tomorrow? No, but it needs to be soon. The rest of it is really, like all these discussions, is going to be so dependent on the clinical impression of our experienced members. Globus, okay. Globus matters. Globus affects people, but is it globus with worrisome signs? That's a different story, and I think we're going to rely, of course, on each other, our members, to make good decisions. So while on the operative side, I think the document really outlines this, I think that the heart of what I'd like to spend the next minute on has to do with what we do in the office. And I know the other colleagues will have something to say. We don't have the luxury of guessing what's in somebody's larynx or pharynx. We don't. We're the experts. We need to figure out why they're hoarse. Now we have to use our common sense. A 65-year-old 2-pack-a-day smoker is a little different acuity in terms of the decision when to see them than somebody who maybe is younger or doesn't have that smoking history, for example. That's an easy example, but that having been said, careful use of our clinic resources, performing safe, flexible, transnasal flexible endoscopy, whether or not you're doing stroboscopy or not, it's pretty much the same in terms of the exposure. And as the Academy Part 1 guidelines, recommended, considering those as not necessarily aerosol generating procedures, but potential procedures is important, and just wearing the appropriate PPE for the patient. But in a case where they're not aerosol generating, being thoughtful about sensible room management is important. I think that's going to be critical to getting the patients that need to see us in the door and keeping the appropriate safe flow going, respectful of our staff, respectful of our patients. And I think that's really important. So doing safe routine transnasal diagnostic endoscopy will be valuable, important. I think the threshold should be, it can't be zero. Obviously, there's a reason we do these things. I think we should have a thoughtful, considered, but essentially relatively low diagnostic threshold to perform these evaluations in a safe way. The appropriate PPE and the appropriate room management. We, as otolaryngologists, should be serving our in this regard.
Thank you, Alan. I think you make a really important point, and as is the case in general, but very specifically to the larynx and associated structures, the preoperative office evaluation is so important, and the flexible nasal laryngoscopy and so on. And so really good PPE, but not being afraid to safely diagnose those patients is key. Because that's going to really, with imaging and other modalities, make your determination regarding the timing of surgery and other aspects as well. So, and so much of this will vary at the local physician level, related to the hospital, their policy, the surgical policy, priority of other cases that may take precedence over what's considered more urgent on an otolaryngological basis, EMTALA issues, Department of Health, and so many other factors. So very interesting perspectives, and thank you for sharing that.
Thank you.
So Dr. Chandrasekhar, if you would speak to otology and neurotology, we'd love to hear your comments, please.
Thank you, Dr. Stetson. I'm really enjoying learning what my colleagues are doing around the head and neck and around the country in a very changeable time. The guidance documents that are presented by the Academy are just that. They are guidance. I think the Academy realizes that we're all qualified ear, nose, and throat surgeons, and the guidance is, as Dr. Marati was saying, how to keep ourselves, our patients, and our staff safe while providing the care that our patients need. So the American Otological Society, of which I'm on the council, and the American Neuro-Otological Society, were very excited to participate in this guidance document, not to tell people when somebody needs a stapes surgery or somebody needs a mastoid, but how in COVID to perform these necessary procedures in a time and in a fashion that keeps everyone safe, minimizes the risk of transmission of disease, maximizes outcomes. So just like Dr. Nathan was saying, just like Dr. Murati was saying, we divided cases into tiers of emergency. So we went from tier 1 being emergent cases, such as a coalescent mastoiditis with an intra or extracranial complication, or a cerebropontine angle tumor with brainstem compression that really has to be done right away, whether or not the patient is COVID positive. Now, if you can delay and get some sort of rapid test that helps the OR team, in a sense, prepare, you can do that. But this is done with full PPE, particularly, as you mentioned, Dr. Stetson, talking about aerosolization of particles, which happens with drilling of the mastoid. We don't know if COVID particles are present in middle ear fluids or in mastoid fluids, but we do know that we create aerosol when we drill. So taking into consideration that, those tier 1 cases really have to go right away. The tier 2 are emergent cases, which should go as quickly as possible, but can be delayed in order to get some degree of COVID testing done. We've all heard of the difficulties of getting accurate COVID testing, whether it be for the disease or for the antibodies. And people are looking into antigen testing now. But whatever is available in your area, with the guidance of your institution, I think is our recommendation. So these tier 2 cases, and there's a whole list in this guidance document, but for example, if there's a person with chronic otitis media or cholesteatoma with an acute facial palsy, that person needs to be attended to rather rapidly, possibly can be temporized medically for a couple of days until they sort of meet the criteria, pass the criteria for either having been recovered from COVID or being COVID negative. If you have an existing implant that's infected and needs to be removed, perhaps you can temporize for a couple of days with intravenous antibiotics, but then you really need to get that foreign body out of the skull. And there's an entire list that the listener and the observer can read through in the guidance document. The third tier are the time sensitive. So it's better to do it sooner rather than later, because if you leave that retraction or that small cholesteatoma on the incus and you leave it there, you know that that incus is going to be eroded. So you're going to take a case with relatively minimal intervention and excellent hearing outcomes and turn it into a case that maybe needs much more intervention and has a possibility of poorer hearing outcomes. If there's somebody with intractable vertigo who is amenable to surgery, we don't want our patients to suffer. Nobody went into medicine to make people suffer. So again, these are people who you want to intervene as quickly as you can, but you would also have the time to either be able to test as well as you can that they are COVID negative or that they are recovered from their infection. And then the fourth tier is the routine scheduling. So these are perhaps a person with otosclerosis who can be delayed but not inordinately, because hearing is in fact fundamental. And so somebody like that, somebody with an uncomplicated attic cholesteatoma, somebody with a slow-growing vestibular schwannoma, but it's growing, somebody with a tympanic membrane perforation. And when I was looking at this guidance document, I noticed that there is certainly overlap, particularly when we look at the pediatric indications. So I like that a lot. I like the fact that AOS, ANS, and ASPO, as well as the Academy as a whole, are looking at these cases with very similar concepts. looking to what we can do in the office, because a lot of otology interventions can be done are done in the office. As my practice has opened up for regular patients for the past 2.5 weeks, you know, I'm realizing that I wear an N95 mask and a surgical mask and gloves and a gown to see all the patients. It's very difficult when they're hearing impaired, so I actually move as far back as possible, take my mask down to communicate if they're having difficulty hearing me. The clear masks that are available are hard to get, and they are not N95 quality. But I'm finding that I really try not to have my assistant in the room if I'm doing something in the ear, because the patient's head is turned away, and really the only aerosol that's generated, even if I'm suctioning a mastoid, is actually the patient's cough. So even though they are wearing a mask while they are undergoing the procedure, I'd ideally like them not to cough at my assistant. So I'm trying to do as many procedures as possible without an assistant in the room to minimize their risk. The one procedure that I'm actually having my assistant in the room for, and I'm seeing a lot of it, somehow I'm seeing a run of benign paroxysmal positional vertigo for the past couple of weeks, is when I'm doing the Dickfall-Pike or I'm doing a cannulus repositioning, the patient is anxious. If they're wearing a mask, they're kind of getting overheated and even more anxious. And so I'll actually often have the patient take off the mask for that portion, because myself and my assistant are wearing our masks. But that's where somehow the more symptomatic, the more nauseous, the more prone to vomiting patients are coming in. So I am finding that I do need my assistant's help with those patients. But I think evaluating the patients as they come into the office with a questionnaire, we're taking everybody's temperature as they enter the office. We're not allowing a companion unless the patient is a child or needs a companion for medical or language issues. We removed many of the chairs in the waiting room so that they can't sit closer than 6 feet from each other. And then we are kind of scheduling the appointments so that the rooms are cleaned in between, but the patients are not waiting any significant length of time in the waiting room. And I think that's really important. I had a funny story where my cochlear implant audiologist had to program somebody that she had never met, because the center that person got implanted at has not opened yet for audiology services. And so the first time this gentleman met her, she was all gussied up in like an N95, a surgical mask, goggles, a face shield, because it was in a hospital clinic. And the deaf patient whom she was turning on for the first time said, "Are you skeeved by me?" Which is a very New York word for "are you grossed out by me?" And everyone burst into laughter. Well, she and the patient, because the family couldn't be there. And she had to explain to him that she did not find him repulsive or gross, but these were the precautions that we have to take these days with COVID. So I think it's really important for patients to understand that we are actually taking these precautions to help them stay healthy as well.
Excellent points. And to your last point, I think educating patients before they come to the office of what to expect and before they get to the OR is very important, so that it's a reasonable process with good expectations. But just to emphasize a comment you made earlier on, this is not a clinical guideline. It's not a clinical consensus statement in the sense of rigor and preparation, but it's also not meant to represent the standard of care per se. And so it's really guidance and will be influenced by evolving data over time and certainly subject to change. Another important thing that you mentioned, there are overlapping procedures in kids and adults or conditions. And one of the nice things about this document is there's some consistency throughout and not a lot of variability in terms of what's considered routine versus emergent and approaches. So important to recognize that, and that has been emphasized as well. Having said that, what about just a brief comment about transtympanic therapy or tympanostomy tubes, not in the OR, but maybe in the office, and the fact that many of us are waiting for ambulatory surgery centers to reopen for more routine or time-sensitive cases, or even more urgent cases than that, that could be performed in an ambulatory center, biopsies and the like. Maybe just a quick comment on that, please.
Sure. Thank you for asking. So obviously, if somebody comes with sudden sensorineural hearing loss, that's an otologic emergency that is dealt with in the office. There is some concern during this COVID pandemic that the administration of systemic steroids can pose some danger, some potential for easier acquisition of COVID infection or worsening of the disease, other than in the cytokine storm where they have to get steroids for that, but worsening of the other forms of the disease. We know that intratympanic injection of steroids is proven to be at least non-inferior, so at least as equivalent in terms of outcomes for hearing success. We ran emergency clinics during the time that most of our offices were closed during the full month of April, and we saw quite a few percentage-wise of sudden sensorineural hearing loss. I don't think because there was an increased incidence, but I think because it's one of the few things that is an emergency, such as epistaxis or other problems that we see as an emergency. For that, it is very comfortable to do an intratympanic injection in the office. Again, the patient has to be prepared. They are wearing their mask. They're turned away from you. If you have an assistant helping, they should be next to you and not across from you. So if the patient coughs, they're not in the plume, even with the patient's mask on. But an adult or a cooperative older child can have a laryngotomy or an injection or a laryngotomy with tube insertion in the office during this time, again, with proper preparation.
Thank you very much, Dr. Chandrasekhar. Those were important considerations. And at this point, let's transition to Dr. McKenna to share some thoughts on the pediatric population and some of the difficulties related to kids. Thank you, Margot.
Thank you. I want to acknowledge the hard work from our committee because it was a very quick turnaround time and a lot of input from a lot of different people, which made it such a, just increased the richness of the document, and also some input from ASPO members, which was very helpful too. One of the issues that came up relatively frequently was in children, they may be more likely to be asymptomatic, and having a child in your office and crying during an exam, that in itself may be an aerosol generating situation. So needing to be particularly cautious about those types of things. In that event, the preoperative testing becomes very important for some of our maybe asymptomatic pediatric patients. So making sure that they do get COVID testing prior to coming to the operating room. And I know that was mentioned in the part 1 of the documents as well. Some of the things we've run into with children with their preoperative testing is being able to tolerate the nasopharyngeal swab and what to do. I've already had one patient who was not able to tolerate it because of developmental delays, and kind of how do you proceed in that situation. So I think, it involves some careful planning on all sides and knowing what to do in the situations that don't follow the typical protocol as you would hope or expect. Some of the things that we wanted to stress were foreign bodies, especially button batteries. Nasal foreign body in the overall scheme of things is lower down in the area of time sensitive, but if there is a concern that it may be a button battery in the nose, then it should be moved up into the emergent category. And similar with any ingested esophageal button battery or an airway foreign body of any type. The places where we had the most conversation back and forth were in the airway, because again, whether a case is emergent, urgent, or time sensitive is very dependent on patient factors and how that patient is doing at any one moment. The fact that something like a tracheostomy may be of less acuity if that patient has a stable intubated airway compared to a baby who needs a slide tracheoplasty, which is an open airway procedure. But if they don't have a stable airway, then they're going to be moved kind of up in the priority list for that. And then we also differentiated between procedures where there would be potential for complication, such as a cochlear implant. If there was a risk for labyrinthitis ossificans, again, is going to move up on the list. Similarly, a endoscopic sinus surgery if there's concern for intracranial complication, or a mastoidectomy if there's concern for additional complication from otitis media.
Excellent, thank you. And I think one of the interesting aspects that you talk about is preoperatively with testing and how young, how well tolerated, and then the big dilemma about reliability and so on. In your institution with kids, how far in advance of the surgery are you doing the testing, and down to what age, or is it every child if possible?
We're doing testing 24 hours beforehand, a sort of drive-through testing station, which has been very successful so far. We are testing all children, all ages. In most cases, it's pretty well tolerated. We do have information from our infectious disease colleagues at our particular center that we have a later generation PCR test that's very reliable with a very, very low rate of false negatives. However, they do stress, as we all do, that it depends on the quality of your sample.
Absolutely, and that's always a rate limiting factor. Excellent. Well, thank you for those thoughts and for your contribution. And at this point, I'd like to turn over to Dr. Hahn for comments as it relates to the rhinology patient.
So thanks, Dr. Stetson. It's been great to be able to have the American Rhinologic Society work together with the American Academy. Partly because, you know, I've been fortunate to wear multiple hats. One of the hats I wore was chair of the Paranasal Sinus Committee, and that was one of the major committees from the Academy that helped build the reopening plan for the for rhinology. And we were able to, the Paranasal Sinus Committee was able to partner with the American Rhinologic Society and together work together to create this resumption rhinology plan. And it was perfect because a lot of our ARS members were asking us for guidance. We were getting questions from hospitals and local facilities. And so the timing of this is perfect. And, you know, a lot of the things that we talked about in the resumption plan was from our own personal experience here at EVMS. We had a COVID-19 team that helped kind of come up with precautionary measures to provide safety to not only the patients, but also to providers. And then that team also developed the reopening plan. So one of the things that we did was split up two teams of faculties. And then we split it by location. During the reopening plan, we had to kind of decide when do we bring those two teams together, which also included residents. And so, and then, you know, in regards to rhinology, if I had to make some key recommendation, I would say make sure you have a phased opening, not only for the office in terms of your clinics, but also have a phased opening plan for your operating procedures. And I'll go into that a little bit. But you know what was ironic was that even though we had this very well thought out plan over a couple of weeks of how to reopen our office and how to reopen our operating rooms, it was overrun or overruled by our local institution. Here in Virginia Beach and Norfolk, our incidence of COVID-19 is very low. our governor is actually a physician, so he understood the process pretty well. So he gave us specific guidance on when we could open. And as soon as he opened it up and allowed us to do elective procedures, since we had a low prevalence of COVID-19, our PPEs were readily available, and we were able to have COVID-19 PCR testing readily available. We were able to open up right away. So even though we were very thoughtful on how to kind of stepwise kind of phase it in, we were kind of told to kind of open everything up right away. And so for our offices, what we did was over a period of a month, kind of phase from our COVID-19 schedule to our regular schedule. And then for our office, in terms of our operating procedures, we kind of broke it up into different categories in terms of urgency. What's kind of unique about rhinology is that those COVID-19 specifically target ACE2 receptors. ACE2 receptors tend to be very high in the respiratory tract, upper respiratory tract and lower respiratory tract. And so anytime we do any type of procedures that are in the nasal cavities, upper respiratory system, like the nasal pharynx, the nasal cavity, you're able to generate these aerosolized particles that may carry COVID-19 that could lead to transmission. And so because of that, it was high risk. And so we broke it up into 4 categories: emergent, urgent, time-sensitive, and standard. Emergent were things that we were doing. So we were operating on apoplexies. That was a case where it was an emergency. We were operating on sinonasal undifferentiated carcinoma and treating them endoscopically. Patients with acute sinusitis with complications, or patients with invasive fungal sinusitis, those are cases that we couldn't wait. I mean, those are cases that we were doing during this period where elective cases were not allowed. As soon as those elective cases were allowed by our governor, we then broke our cases that were backlogged into different cases. So patients with sinonasal benign tumors, or patients with severe nasal polyps that were making their asthma worse. Those were things that we kind of put into different categories, and then started having our office call these patients and start scheduling them in. And so something like a septoplasty and turbinate reduction, those were kind of low on our list of patients. Now, in order to get them into our operating room, we did a couple of things. Because the COVID-19 PCR testing was readily available, and we could get those results within 24 hours, we had them get tested. And so then after they were tested, and they had to be COVID-19 negative, we had to have, after they got tested, they had to be quarantined. So by the time they came in, we knew for sure that they would be COVID-19 negative. And even with them being COVID-19 negative, it was the hospital policy, the surgical exec committee, that decided that what type of protective gears we should wear. And for these surgical procedures that open the mucosa where the COVID-19 tends to reside, like the oral pharynx and nasal pharynx and nasal cavities, everybody in the operating room had to wear N95 and goggles. Before we had the COVID-19 testing, when we didn't know if they were positive, we were wearing N95 masks and respiratory hoods for that extra protection. But knowing that they're COVID negative, we don't have to wear the respiratory hood as much and don't have to be as safe. And so that was one of the ways we kind of staged and phased in the operating procedures. And we did this, and we kind of looked at the cases every week to make sure that we appropriately put the right patients in and get them in as soon as we could. Now, the office procedures was a little bit challenging for us taking care of rhinology patients, because for us, nasal endoscopy is part of the physical exam. And so during the process of the COVID-19 period, where we had reduced in-person visits, we were relying on telehealth to kind of take care of our rhinology patients. It was not easy. It was difficult because you wanted to scope the patient. And so if there were some patients we were seeing in telehealth where you really wanted to see the patient, we would make the patient come in and do a nasal endoscopy. The problem with the nasal endoscopy, and this was a recent paper that just got accepted by the white paper, was that the nasal endoscopy and spraying the nose with anesthesia and decongestant can produce aerosolized generating particles. So because of that, you had to have a little bit of extra caution. And so during the time we were scoping the patient, we actually did not spray them with any medication. And we wore goggles and we wore masks. And surprisingly, a lot of these patients tolerated nasal endoscopy without any anesthetic or decongestion. So we were able to do that pretty well. And then one of the other things that we tried to do was, as everybody kind of knows, some of the earlier symptoms of COVID-19 is loss of smell, and that's gotten a lot of press. And so for us, we would try to screen the patients ahead of time, try to figure out who has it by symptoms, and we would also check their temperatures. And so eventually we got to the point where we were very comfortable with patients coming in and having a low suspicion of COVID-19. You know, what was interesting was, you know, before the COVID-19 process, I was seeing in general about, 15 to 17 patients in half a day. With the COVID-19 process and reopening our office, and we're transitioning from a telehealth to in-person visit, what we're noticing is in order to try to distance patients from overlapping in the waiting room and overlapping in the office, we decrease the number of patients we're seeing. So we're seeing about 10 patients in half a day. One of the things that was kind of interesting when we first started out was we didn't know how long we can wait after performing a nasal endoscopy that we can see our next patient. So initially we were very careful, and after we do a nasal endoscopy, we waited anywhere from 1 to 3 hours. You can imagine if we only have 3 rooms and you have to wait 3 hours to put another patient in, you couldn't see very much. So we had to get a couple of information. One of the things that we had to obtain was the air change per hour, the ACH. And the reason why that was important was that would determine how quickly any aerosolized particles will be cleared from the room. When we realized that for our patient rooms, the ACH was about 6, we knew that 99.9% of the particles will be cleared by the room in an hour. So even after a debridement or a nasal endoscopy, we can wait an hour and then put the patient in. So because of that, we can't see as many patients as we used to, but I think it's better to be more cautious than it is to be safe, partly because a lot of things is there's no specific guidance and there's no strong evidence. I would say a lot of the things that I've learned were through the experiences from Asia and from Europe when they went through the SARS and MERS. They have published some articles regarding some of the reopening process. So that was some of the papers that we read to try to incorporate into the reopening process for rhinology.
Excellent. Thank you, Dr. Horn. And certainly a lot of factors that go into this. And I'm sure central to all of the specialties, are you finding, and certainly anyone can answer, please, that there are procedures that may be more minimally invasive that you're transitioning to the office, instead of the OR in light of some of the COVID issues and availability of OR time or lack of ambulatory surgery center availability at this point?
Not on my end. I think where the where we do things hasn't changed for me so far, but it is something to keep an eye on. That's interesting. I don't have the ASC, changes facing me, but I understand what you're saying.
From a pediatric perspective, potentially there's more of a lean in the opposite direction to do more things in the operating room that we might have otherwise done in the clinic, like nasal cautery, because of the availability of COVID testing preoperatively for the operating room that we currently don't have for our ambulatory settings.
Yeah, for head and neck, we haven't really seen a change in where we do these procedures. We've been fortunate though. We scrub our clinic lists and look at which patients are probably going to need a scope, and we'll get those patients COVID tested as well, so we can do procedures in the office as well.
Excellent. And I think even with OR availability or ASC availability, the testing is still potentially a rate limiting factor because that varies so significantly in terms of resources, availability, and reliability depending where one practices.
So one of the interesting things my patient pointed out to me today, I think it was today, was he in fact has a cholesteatoma, had a facial palsy which recovered and needs to be scheduled, and he fell into that sweet spot of where everything was closed. And even though he's a young man, healthy, he's very concerned that he's going to have surgery, there's going to be a resurgence of disease, and then somehow all the offices will be closed again and he won't get in. And I think, as we're talking about how we're educating our patients, telling them our contingency plans and telling them, New York, New Jersey are still a huge epicenter of disease here. We don't have the kind of testing you guys have down in Virginia, frankly, easily available to us. So I think educating them that we're going to continue to stay open, that we're going to continue to be able to offer the postoperative care. And I think Sherry Ann mentioned people are really hesitant to come into the hospital. And we know this not just from head and neck cancers or other ENT problems that are going awry, but we actually know this from the myocardial infarction data. We know this from the stroke data. People are very scared. So I think this is a very good time as we are coming to grips, as we actually are flattening the curve, to reach out to educate patients as to how to call comfortably, how to use telemedicine as an initial foray into the medical center, so that then we can help determine if they need to be seen or not. And I think KJ Lee had a beautiful little piece that he wrote, and he talked about how telemedicine has advanced 5 years and 6 weeks because we just needed to do it. Necessity being the mother of invention. So I think patients are more comfortable with it. It certainly doesn't supplant a full head and neck exam, but it can give us an idea of who needs to come in, who needs to be scheduled for what type of procedure pretty well.
So one of the things that I think really changed was a shift in how we treat patients was the COVID PCR testing. Once that was available, we knew relatively sure that these patients were COVID-19 negative patients. And if they tested positive, we did not operate on them unless there was a true emergency. And even then, we would try to wait. So if someone had a COVID-19 positive that was apoplexy, we'd see if we can try to treat them medically and wait a little bit if we could. So that PCR testing has really allowed us to be more comfortable and be less worried about the safety of the patient and the providers who are taking care of the patient. We also have COVID-19 antibody testing. Now, how that's clinically relevant is not sure, but I will tell you, when we do the COVID-19 antibody testing, we test for both IgM and IgG. Now, if the IgM is positive, I would suspect that they may be one of those 25% patient who was asymptomatic, and I would hold off on doing surgery and actually test them with a PCR, partly because the IgM is such an acute process within the first 2 weeks. So I would kind of be a little bit wary about operating on a patient with an IgM that's positive. If the IgG is positive, they're most likely the infectious process is probably passed, and so we're not worried about that as much.
Absolutely, and I think again, it is the veracity, the availability, the reliability of PCR and antibody testing that's really going to drive this. And to Dr. Chandrasekhar's point, I think earning the confidence and trust of the patient is important, getting them back into the office, maybe more so getting them into the hospital and the operating room. But similarly, our colleagues in the paramedical fields in the OR, our scrub teams and surgical colleagues, we need to be able to ensure quality and safety within these recommendations. Again, recognizing that this is not a guideline per se, but guidance that we can all do things well and safely and in a timely fashion. In closing, I'd like to thank all of the audience for joining us for this podcast, and I'd like to remind you to please continue to visit the COVID-19 resource page at entnet.org and to join the conversation at ENT Connect, which has been a very robust forum. We are sharing all information and inspiration during this challenging time. And so my final comment is the wonderful collaboration that has emerged within the Academy and its sister organizations. And now, as always, we are one. So thank you all, and thank you to our membership and participants. Onwards and forwards.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.